Hello, this is Jena Quinn, and today you are listening to Little Patients, Big Healthcare. My name's Dr. Jena Quinn, CEO and co-founder of Perfecting Peds. Today, I am ecstatic to introduce you to a huge celebrity, entrepreneurial icon, and co-founder of Cost Plus Drugs. Please help me welcome Mark Cuban.
Thank you.
Thanks for having me on.
Welcome, Mark Cuban. I'm so grateful to have you on. As an entrepreneur myself, obviously, this is a surreal moment. So the first thing that I want to talk to you about is how your entrepreneurial started in Pittsburgh. So we live very close. I'm from Philadelphia. You're from Pittsburgh. There is a little bit of rivalry there. You will hear it in my terrible Philadelphia accent. But that being said, from where you started your entrepreneurial journey to where you are now, did you ever think that you would take this journey and be in the healthcare industry?
Oh, yeah. When I was 10 years old, I thought for sure, at some point I would create a company that sells medications and manufactures and uses AI. I just wasn't smart enough back then to invest in any of the companies that would get there. No, never in my wildest dreams. Never in my wildest dreams. I just, wanted to be able to afford college, get a good job, start a business someday, and see where that took me. And then, knock on wood, I've been the luckiest guy in the world.
Yeah, so I became a pharmacist, and I'm elated, Mark. So how cool to have you advocate for just the value of the pharmacist, which really goes unrecognized and underappreciated in the United States. So I'm so excited to pick your brain about that and how that even came about. But my grandfather was a quote unquote old school pharmacist, had an independent pharmacy where he compounded. My grandmom was the soda girl, the soda jerk. And so
that's awesome. In Philly?
Yeah, in Philly. And so it's really cool. I mean, they both passed recently, but they were my biggest supporters and fans. And so that's how I got interested in pharmacy. And then my sister, who's still my best friend to date, struggled with epilepsy growing up. And so from a really young age, I knew how to give the Diastat, like the rescue medication, to my sister. And because there was a 10-year age gap, I was like the parent she never wanted, but I like to think I was slightly cooler. But I'd love to hear, Mark, if any of your personal stories tied to your why of co-founding Cost Plus Drugs.
Yes and no. I mean, we've all had bad experiences with the healthcare system, particularly the economic side. My mom died from cancer 3 years ago now, almost 4 years ago. And we took her in Pittsburgh to St. Clair Hospital. And she had cancer, and we knew she had cancer, and she needed a PET scan. And rather than while she was in the hospital, just going and getting the PET scan while she was already there, they made her check out, go home for 3 days, and then come back so that they can collect whatever it was they were going to collect from the insurance company. And that pissed me off to no end. I mean, rather than doing it while we were there to have to go through all these different steps just so they can make some more money. And I told them I would just pay for it, right? Don't make us go home and then come back. It's already painful enough for her. Just tell me what you're going to make and I'll pay for it. And they were like, no, we can't do that. I'm like, you don't want to know what I said. And so, that was a big part of understanding just how messed up the system is, because they don't do things, the right way for their customers or patients. They do them to maximize revenue. And that's why the revenue cycle management industry is multi-billion dollars. I don't even know how many billions. And so, those are the types of things that when I got a cold email from Alex, Dr. Oshmayansky, and said he wanted to create a compounding pharmacy to be able to manufacture pediatric cancer drugs because they go in short supply all the time, and other sterile injectables with the fill and finish facility in Dallas, I was like, okay. And then as I started digging in more, that was right when the pharma bro was jacking up the price of Daraprim. And I was like, this is just insane. this whole thing from top to bottom is just such a mess. Somebody's got to find a way to do it. Everybody seems to be battling on the edges, and nobody seemed to be trying to undermine the way it's always been done. And so that was kind of my motivation.
There may have been a trend that you started with the new launch and announcement of Tom Brady being the chief wellness officer of eMed, as well as the new Trump RX. I would love to know, what are your opinions of all these new companies that are being spun up that are based off of medication access, just like cost plus drugs?
Yeah, the economics of healthcare are always an arbitrage because it's such a big industry. When you have a $5 trillion marketplace, and I like Linda Yaccarino, know Tom, and I'm happy with what they're doing with eMed. We're working with them, because there's always an opportunity to improve efficiency and patient support and results. But that's also a reflection of the inefficiencies of the incumbents, right? Otherwise, there wouldn't be that opportunity. And it's the same with Trump RX. We can talk about MFNs, but it's a portal site. It's like Yahoo was back in the day, right? It connects, and there's nothing wrong with that. It's a positive, and to paraphrase Michael Jordan and his sneakers comment. But it's just, you're always going to see people trying to find ways to optimize where there are inefficiencies. But then I try to look at what are the structural problems that put us in that position in the first place. I don't need to try to create a company that squeezes out a few more dollars so I can make a few more dollars. I just want to turn everything upside down so that it works. Because while, what eMed is doing is great, what Trump RX is doing is good, it doesn't fundamentally change anything. And that's really what we try to do, is fundamentally change things.
Okay, I'm excited because I'm going to challenge you to see how
Please.
you would deal with some of the flipping the pediatric healthcare upside down in a couple different ways. But I would love to see your opinion as both an investor and an entrepreneur. An alarming stat was just released that pediatrics, just children, make up a quarter of the entire US population. However, only 1.6% of VC money goes into pediatric innovation. We know, and we see it every day at the Perfecting Peds, that the amount of chronic illnesses on children are compounding, obesity, and just things like, a neonate. Now we can excitingly keep a child alive longer. And so as those NICU graduates, they have a lot of needs as they come out, and our chronic illnesses are increasing substantially. When we talk about the healthcare ecosystem, more specifically the economics behind it, if we can get ahead of these chronic illnesses, we can drive down a lot of the total cost of care that's going towards healthcare dollars. So in your opinion, both as an investor and as an entrepreneur, how would you disrupt the current, disparity and draw more attention to pediatrics? And these kids really need it the most.
Sure, of course. I mean, nobody wants children to be sick and not get cared for. But the last place I would look for help is from VCs, because, they have economic interests that drive their decision making, and that doesn't necessarily align with the best interests of children or their parents. And so, as you mentioned, trying to get ahead of chronic illnesses is the best way to reduce the amount of chronic illnesses. And that's where we fall down a lot. Whether it's daycare or, crowding in daycare that just helps make kids sicker rather than healthier, whether it's education opportunities for parents in a world where they don't have the time to go get educated and there aren't the tools, and there's a lot of conversations and studies about social determinants of health. And I've always thought that it's more about aligning all the organizations within a community so that they work together rather than replicate what each other's doing. Because there's way too many charities and not enough charity, if you know what I'm saying, right? Where everybody wants to help kids and they create a charity in the name of somebody that, tragically died or whatever the case may be, or was ill, and they go off and do their own thing and raise money. Then 25 others are in the same space and they go off and try to raise money. And I'm sure you hear from all these charities all the time, work with us because we're trying to solve A, B, or C. But then you hear from somebody else who's trying to solve, the same thing. And then you hear from the national organization trying to do the same thing and wants to have this big fundraiser. None of these things are aligned or organized. And I think, if I were going to dive in, that's what I would do. I would try to organize and align all these things so there's not duplication. Because, rather than worried about the VC money, there's so many, pick whatever area, pediatric cancer, and within pediatric cancer, 1,000 different, scenarios. But there's always going to be 5 of them for each one of those cancers. And they're all competing because they all want theirs to be the biggest, the best, and think they're going to have the most impact. And I would truly pass a law that says before you can open a charity within any area related to medicine or anything for that matter, you have to make sure there's not one already functioning that isn't doing what you intend to do. Because that duplication just eats up resources that could go to cures, that could go to support, to whatever it is. That's part one. And then part two, as I referred to, I would look at all the organizations that do focus on social determinants of health, from churches to schools to police stations to whatever it may be, plus charities, and make them align on within any particular sickness or whatever you want, cancer, whatever it may be. And by doing that, you get more money focused where it needs to be focused.
Absolutely. That's really cool to think, and not the way I would have approached it. So that's an amazing answer. Mark, I know we had talked about this earlier. I really love how you've come to elevate the role of a pharmacist. And so I had spoken, my grandfather thought right before he passed, I shared, like, I'm gonna start this company and we're not going to touch any medications. And he's like, what? What are you doing? So throughout my career as a pharmacist, I've never touched meds unless a child was passing. I would go to the bedside and help draw up the meds. But outside of that, I was always the liaison between the nurses, the providers, the parents, to really be that, as I joke, like the ultimate dork in pharmacology. And so we have these pharmacists who have doctorate level training who really have been labeled to most of the public as just pill pushers, right? And so they'll say,
and that's crazy, right? That's crazy. Right. I mean, at least they've extended it some, so you could, give vaccines, right, and give, advice on vaccines. And now we see where the chickenpox virus, shingles virus vaccine,
varicella.
Varicella now has other properties that are better that the pharmacist is going to know probably before your family doctor may know, right? And so I think allowing pharmacists not only to support vaccines, but also to do replenishment prescriptions. So that if you do have somebody who needs, like I need Synthroid, right? I take levothyroxine. There's no reason I should have to go to my doctor to get replenished for levothyroxine, right? There's just no good reason whatsoever. And there's 100 medicines that fall into the same scenario. And now you have scenarios with biosimilars versus the legacy brand drugs that are dramatically cheaper. And you have the big PBMs fighting ways to use those to retain margin. There's no reason why, particularly since many of them are injectables, we've been trained by GLP-1s to allow people to self-inject or get help from their pharmacists or vaccines for that matter. There's no reason pharmacists can't be the ones that prescribe that. The challenge for pharmacists is how they pay for drugs, because it makes it so that, they don't get remunerated for their time, right? The fill fees, except for Cost Plus Drugs, Team Cuban card, right, in our pharmacy network, where we pay $12 per fill. But most pharmacists, for brand medications in particular, don't even get reimbursed for their costs, let alone for their time. Yeah. And so I think in order to get to the point where pharmacists can truly, if they have the PhD, et cetera, not, your traditional pharmacy tech, that type of person, because there's different levels of education. And I'm not the qualified one to tell you which one is which. We have Aaron Albert at Cost Plus that knows that stuff better than I do. But at the same time, if they are qualified and it's chronic, or if it's something that the patient needs help administering or learning how to administer, pharmacists, can do that all day long. And I think, it may well be going to your pharmacist, paying $10 and having them administer your GLP-1 injection or your Stelara biosimilar injection, whatever it may be. It may well be, putting in a little baby clinic in there, where you can do infusions or other things. So I'm all for expanding the qualitative aspects for pharmacies, because right now, particularly where we're seeing more and more hospitals or care deserts, a pharmacy can be pharmacy is the last 5 feet of support for a lot of people, particularly older people. And so I think it's incredibly valuable, and they should be able to have more responsibility and more authority to make some of those decisions and prescribe those medications.
Yeah, because outside of a few states where pharmacists can bill for MTM services, what we're trying to do is, flip the model on its head and say, hey, can you reimburse us for clinical services? And
Sure.
not the MTM fees, but actually the fees that we deserve.
Right, and you guys can do service agreements with PBMs and with manufacturers. And I've talked to many manufacturers who have said, we'd love to do service agreements with pharmacies, because that's a great way for them to keep people on that medication and to make sure that they adhere. And the challenge is, it's hard for anybody within the pharmacy industry to do those negotiations for everybody. It's not something your PSAO is going to do. And there's some great people within the industry, the Doug Hueys of the world, that really make an effort to create those new revenue sources. But I think there's a lot more that you can do to generate service revenue for pharmacies.
Yeah, and I'm going to even one up you. Like, I think continuing medications that a patient's on, but then also, like I said, we're so dorky. We're always thinking about the kinetics and what are we supposed to be monitoring. So like, one of the biggest interventions that we have as pharmacists is usually like, okay, this drug's going to affect your cholesterol and your sugar and your blood pressure. Let's monitor all those things so that
for sure.
So I think that's truly where, too, we can be buddies with the prescriber to say, hey, you know what? We have this kid on an antipsychotic. His blood glucose is going up. We can either, transition to an alternative agent, or we can add on a medication that will help decrease the blood.
Absolutely. And it could even be simpler stuff. Like I said, I take levothyroxine, and I also, because I went vegetarian, my ferritin levels went down. So I'm taking the supplemental iron, and I was taking them both at the same time. And honestly, until I looked at it on ChatGPT, I had no idea you can't take anything like that at the same time, right? And so now I switched them up like 6 hours apart, and my TSH levels went way, 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 way down. So I agree with you. You can't have enough intelligence or enough intelligent people supporting patients. It's hugely important.
Yeah. And I'm glad you figured that out. And hopefully you just got it monitored after you separated them.
Because fun fact, a pharmacist would tell you, would be the only one to tell you, if you space it out every other day, Mark, it decreases your constipation, but it still actually increases the absorption by separating and doing it every other day.
Oh, no, trust me. It's been a couple years since I figured it out, so I'm good. Everything's free-flowing in the Cuban household.
I'd love to hear, Mark. So, you really talk about and focus on brand access being available. I can tell you, personally, growing up with a little sister with epilepsy, every time we tried to move her off brand Keppra, she would have a seizure. And there's certain disease states, like you just brought up, your Synthroid, your levothyroxine, when we...
People have different sensitivities, no question.
Right. And so, when you advocate for brand access in certain situations, what problem are you trying to solve? Because that's where my brain goes as a pharmacist.
And so from the economic side, right, I'm not trying to be the doctor or the pharmacist, because I'm not trying to interface with the patient and give advice. I'm the last person, except maybe on constipation. That I'm an expert, or used to be. But the rest of the way, you have to look at brand access, because if you have a patient that needs Keppra, right, when it was, and you need it as a brand, before there was a generic, right, you knew the problems that pharmacies had just being able to afford to carry it.
Right.
Or just getting the patients to get the PBM from their insurance company to allow you to provide it. Right. Yep. And if you provided it, getting a full reimbursement so you didn't lose money on it. All those things impact the pharmacy's ability to serve their patients. And so what we look at is, how can we change all that? And the fundamental place where it needs to start changing is the fact that the brand manufacturers sell to wholesalers at full retail price, at WAC price. That's the only industry that I know of in the world that does that. If they came on Shark Tank and someone says, yeah, we're a wholesaler and we buy at the retail price, I'd be like, how do you sell at wholesale as a wholesaler when you're buying at retail price?
That's crazy.
And you know how it goes downhill from there. The wholesaler buys at retail price, and then they get a prompt pay discount, and then they get, a digital services for information discount, and they make about 5, 6, 7%, right? So they're paying retail price. And then the pharmacy says, okay, I need to buy that drug from the wholesaler, that brand drug. And let's just say it's $600 WAC. Now you're paying WAC -5 or WAC -7, right? So you're paying $570 for that $600 drug. Now, that creates all the problems of the economics in pharmacy for brands, because now you have so much cash out of pocket, it's sunk inventory. And so you are dependent on your wholesaler even more to ship to you next day, which increases their cost to ship, right? Because you can't inventory anything that's expensive at all. And to make matters worse, once you fill a prescription for that $600 brand drug, you don't know how much you're going to be reimbursed by their PBM. You file that claim and they're going to underpay you. Then they're going to audit it after the fact to try to get more money from you. And then they're going to find other ways to try to make your life miserable by taking more money via a coupon, a claims fee, whatever it may be. Because what these PBMs do, because the system is allowed to go in this direction, they look for the link with the least amount of leverage. And the independent pharmacies are the weakest link. Just like on the medical side, independent physicians are in the exact same position. They get underpaid, late pay, clawed back, left and right. And so how do you change all this? Every ounce that you have needs to go to manufacturers and say, if you're going to work with these big three wholesalers, you need to sell it to them at net. You as the manufacturer, the brand manufacturer, will probably make a little bit more money because you don't have to deal with all the mishigas of paying the prompt payment rebates or reimbursement and all that. And so by selling, let's just say it's a $600 brand drug, and it's got a 50% rebate. Sell it at $300 instead of $600. Yeah. Now the pharmacy can buy for $300 plus a markup. If that wholesaler was making $30, 5%, right? Sell it to the pharmacy for $330. And guess what? Everything changes. Yeah. You don't have as much cash out of pocket. The wholesaler makes just the same amount of money. They could even charge you a little bit more to make some money off the float, right? Fine. Right? Or to make up what they're not making off the float. But now if a patient comes in without insurance and you're out of pocket $340, you can sell it to them for $350 and be ahead of the game. Now you got to sell it to them basically for WAC. And what happens when you sell it for WAC? Chances are they can't afford it and they go without.
Yeah.
And then what happens if you have great insurance, but you have a $2,000 deductible and you're in the deductible phase for that $600 brand? You're paying full whack.
Yeah, I was going to say, you're not getting it either.
Right. And that's the big lie of the PBMs, right? Because if you have to pay full whack while you're in your deductible phase, whether you're ACA, whether you're for a self-insured company, whatever it may be, right? Think about what happens. A, you might not get it because it's a lot more money. B, right, half of that is a rebate. So effectively, when you're in your deductible phase, that rebate, that $300 in rebate goes to the PBM, who keeps part of it and then sends it to the employer, right? If it's a self-insured employer. So effectively, your sickest employee or their family member is writing a check to you for that rebate so you can put it on your balance sheet. And when I sit and talk to CEOs and I say, look, somebody that works for you is going to get sick because they couldn't afford to pay full whack during their deductible phase. And you saw it all the time at your grandfather's counter, or they can't afford it. They paid the $600, but that money is going right to the CEO's bank account for the company, right? Yep. So your sickest employees are paying your rebate. Is that what you want in a Wall Street Journal article? Because I'm going to help them write it every single time. And I say to them, look, I understand that it's not the core competency of a CEO to understand how their pharmacy benefits work. But this is the reality. You talk about your costs going up and you want, your lower costs for the company. But as long as those deductibles go up and up and up and up, and oh my God, if you have like an ACA silver plan, you're screwed. Because most people can't afford a $400 bill, let alone a $5,000 deductible and $9,400, whatever it is now, out of pocket, max out of pocket. So this whole thing and all that comes down on the independent pharmacist.
It does.
All of it. And then you have to take the risk of saying, I can't afford to lose this. What about my patient? And a lot of pharmacies will say, well, okay, I'll take a $10 loss or $20 loss. Can't afford the GLP-1 loss. So I'll send it to a big chain pharmacy who gets reimbursed the full amount. It's just wrong. But all this starts with the fact that manufacturers sell to the big wholesalers at whack. If they were to sell at net, all this gets better. It's not completely solved, but all of it gets better.
And I would argue, and I think every independent pharmacy owner, now I've never owned a pharmacy in a way, this is obviously virtual and we don't have medications, but with independent pharmacies, a lot of times they're so mom and pop, they take substantially better care of their patients.
Oh yeah, because it's personal. It's personal to them, of course. You wouldn't expect it any other way. I say it all the time to brand manufacturers. That last 5 feet from the counter where the pharmacist is standing to the patient is the most important 5 feet in your entire supply chain, because that's where they determine if someone lives or dies, right? Gets their medication and adheres to it, or has any conflicts or contraindications like you referred to. And you need those pharmacists to stay alive. And they all say yes. They all agree. And then the next words are, but the big PBM.
Right. And they're not going to pay so in independent pharmacy owners, I feel like they have a different mindset where they're like, I'm going to take that extra second to review the patient's chart to make sure they're safe.
Yeah, of course.
And then they're doing it for free. Like as a profession, we've really gone down a path of advocating for all of our services, not just the dispensing of meds.
For sure.
And because we've done such a job, now all the major retail pharmacies are buying up the independent pharmacies, and they're
and not just that, right? Because they know that, because one of them is owned by a PBM, right? They know that they're under reimbursing, and it's just a matter of time before you go out of business. No one can stay, again, you come on Shark Tank, we're laughing you out. There's just no chance we're going to invest in an independent pharmacy that gets under reimbursed for their most prevalent medications, the big insurance companies. And today, by the way, Senator Elizabeth Warren proposed legislation that would break up the biggest insurance companies or make them divest all their non-insurance assets, which I think is critically important, because we've seen, and pharmacists have been really happy about all the legislation that has put PBMs under the microscope. But what they've ignored until this legislation today is that those big PBMs either own or are owned by insurance companies and have thousands of affiliates, or subsidiaries, right? And all they're doing is playing whack-a-mole. They created rebate GPOs to hide the rebate money from the self-insured employers, right? And so you can't just hide it in rebate GPOs anymore. So they'll create new fees. There'll be fees that employers pay, for A, B, or C, or there'll be a per member per month amount that they pay in order to get the cost plus pricing that they're offering them, that they're saying they're going to change to. There's going to be all kinds of games that are played, and it'll be, over the next 5 years, it'll be a game of whack-a-mole or hide and seek, if you will, trying to find out where those fees are. So I'm really excited about this plan to try to break up the big insurance companies. And I'm a libertarian at heart. I mean, you saw after all this legislation came out, and for the quarterly earnings conference calls for those big insurance companies, they're saying we don't expect any impact. They'll make it up on specialty drugs.
Oh, a lot of people don't know that, to just dose a medication for a child, you need their weight. What has happened in the U.S. is that because I guess I don't even know why, and I can't figure it out. But basically, the big retailers don't mandate that the child's weight is on the script, and that's the only way that a pharmacist can verify
That's interesting.
that the
I
script's
didn't know.
right. They'll tell you that it takes the pharmacist too much time, so they don't want to mandate the weight. So we know statistically that kids are 3 times more likely than adults to be a victim of a medication error. Yet the public's still not doing anything about it. And I don't know if a lot of people know that at that point of verification.
What are we doing? What are we doing at Cost Plus? Are we asking for the weight?
Well, I don't know. I hope so. That's what I want to know. I also want to know
I don't know either, right? So send me an email and I'll follow up because it's something we need to do.
I would love to know. And I love that you said like the last 5 feet's the most important. And at Cost Plus Drugs, what are you doing? How's the launch going? And 2, when you think about the intricacies of pediatrics, the need for the weight, and even more so, what you're talking about, the likelihood of needing a compounded medication goes up significantly because a lot of these kiddos are getting G-tube fed, or they can't swallow a pill, or we're doing wacky doses from commercially available products and crushing it and then pulling back a certain amount. Right. So I would love your take on all of that.
We can only do what we can do. I wasn't aware of the weight thing, and that's something, if you email me, I'll connect to the right people so we can ask for it. In terms of uniquely compounded drugs, we compound sterile injectables for hospitals and clinics, as I mentioned earlier, but we don't do individual compounding requests.
Got it. And how has the launch been? Do you know how many kids?
Oh, it's been great. No, it's been great, right? Because we would always we'd want to buy from you, my child needs A, B, or C, and we couldn't take scripts for kids. Now we can.
I love that. Yeah, actually, before you guys launched, I had tried because I had a kiddo that was 17, and I was like, damn, I can't get it. But it's so easy to get the medication in that, and it's so.
That's the whole idea. Yeah.
We love it, and we'll be using it on our
Thank you. CostPlusDrugs.com for everybody.
Cost Plus Drug has helped so many patients and now families with Cost Plus kids to get transparent access to medications. And with that, I would love to know, as an entrepreneur, we're always thinking about the future. In 10 years, what do you think is going to be the biggest impact that Cost Plus Drugs has made in the healthcare ecosystem?
I think just changing the economics. Hopefully we're out of business. Our retail website is out of business because everybody knows what the cost is and everybody's being charged, less than cost plus 15% like we charge. Because our mission wasn't to make a lot of money. I've got plenty of money, right? Our mission was to really have an impact and change the game. Now, the other sides of our business, the Cost Plus Marketplace, same thing, right? Because there should really be no reason why our little company sells all this stuff for less. It really makes no sense. But where we've really changed things, and I think will have the longest legacy impact, is in our manufacturing. Because what started as just being able to make sterile injectables, we are now working on trying to make generic tablets. The only thing holding us back, because we can make them cheaper than we can buy them from India. The only thing holding us back is they have this thing called ANDA, which is the new drug applications, and they cost $365,000 each. And to try to do them for 1,000 drugs, even for 10 drugs, just destroys the economics. And so we're trying to get waivers on those fees. That's part one. Part two, we also have made our manufacturing modular. So we actually make them in these pods, these tractor trailer assemblies that we can manufacture pretty much anything in there. So if there's a natural disaster somewhere, or even better, we've expanded it now. And Alex, my partner, is a rocket scientist, literally, to be able to put all this stuff together. But what we're about to test and we'll be able to do is manufacture N of 1 medications. So for those kids who are one of the 6 people in the world that have some particular disease state, right? There's some researcher that their parents raised money for that are working on trying to find a solution. Well, right now, in order for them to create that injectable that they may need, takes 6 months and at least $500,000 because you have to stop the for that factory that's making it, they have to stop all their runs in order to be able to do it. We do it in our tractor trailer pod, and hopefully, we'll be able to cut the cost from $500,000 or more to $50,000 and cut the amount of time it takes from, whatever it is, 6 months to 2 to 3 months. And I think that will be our greatest impact, because that's something that is unique to us. That's really, truly AI that we develop using, and is something we'll be able to sell around the world.
I didn't know that fun fact. Cool. The tractor trailer pod. How cool.
Our pods. Yep. The cost plus pods.
Okay. I was listening to another podcast of yours today, and something that really hit me as a entrepreneur and founder was, you said, I like to continuously ask, if I was to restart this business today, what would I do first? And so I would love to know, if you were to restart Cost Plus Drugs today, what would be the first thing you would do?
I think I'd do it the same way, because we had to be lean and mean to understand how the market would respond, because we still have spent no money on marketing or advertising. It's all word of mouth.
Amazing.
And that's how we're able to keep prices so low. So I think I would do that part the same. I think we would have worked on the AI first before we started the manufacturing, just to save some time and money. And then, it's taken me time to learn how all the industry elements of the industry interconnect on the healthcare economics. Yep. The relationship between the insurance companies and the PBMs and the self-insured employers, all these relationships. It's like anybody who truly understands how they all fit together won't talk about it because they're complicit in it. Or, then there's somebody like me trying to learn it, trying to blow it all up so that we can undermine the way it's always been done, so that it can be done the right way. The perfect example is, it was always insane to me that, as I said, the wholesalers bought at retail price. And so now the question is, and I would have gotten into this sooner, how do I help change that so that we can buy, because we don't carry a lot of brands, simply because those big PBMs tell the manufacturers, the brand manufacturers, don't sell to cost plus or give them rebates, right? Because we don't want to undermine our pricing for brands. Because they know if we got, if they got 50% rebate and we got 30% rebate on that $600 drug, that's what? $420 plus 15%, that's 42 and 20, 63, $483, right? Versus them selling it at $600 whack, that undermines everything that they're doing.
Right.
And so they're stopping. So I would have been ahead of that better than I was.
I have one more, because I have 3 little girls. One's an 8-year-old who has taken a liking to entrepreneurship. She has found her product market fit in Girl Scout cookies in Yeah, hold on. She goes to assisted living homes and sells them and slays it.
Good for her. Good for her.
I told her I was talking to you today. She's even watched Shark Tank with me. I said, all right, what's the one question you want me to ask Mark from you? Her name's Peyton. And she said, of all the businesses and all the investments and all your companies, what has been your favorite and why?
They're all my children. Appreciate it, guys. Thank you.
Thank you, Mark.